Hello, my name is Anna Gritsa. I'm Associated Professor in the Department of General Practice Family Medicine. The topic of our lecture is medical help in the case of pain syndrome. Pain is a universally understood sign of disease. It's also the most common symptom that causes people to seek medical attention. The history and physical examination help clinicians to identify the difference between types of pain. Precise and systematic pain assessment is required to make the correct diagnosis and thus to establish the most efficacious treatment plan for patients who present with. The somatosensory system involves in the conscious perception of touch, pressure, pain, temperature, position, movement, and vibration that arises from the muscles, joints, skin, and fascia. These third neurons are relayed side system carry sensation detected in the periphery, those spinal cord, brainstem, and thalamic relay nucleus pathways to the sensory cortex in the parietal lobe. Impulses from receptors travel via sensory afferents to the dorsal root ganglia, the site of the first order neuron cell bodies. Their axons then travel ipsilaterally and contralaterally via the spinal cord. Second order neuron cell body allocated in the dorsal horn of medulla nuclei. Third order neurons allocated in the thalamus. The functional magnetic resonance imaging shows blood oxygen level dependent responses to pulsed peripheral ultrasonographic stimulation of somatosensory circuits in the patients. Pain etiology. The category of pain is nociceptive, neuropathic, psychogenic. Different types of pain tend to respond to the different treatment. The identification of pain type during pain assessment is very important. Nociceptive pain. Nociception is a normal physiological response to stimuli initiated by nociceptors, which detect mechanical, thermal, or chemical changes. Nociceptive pain arises from activation of nociceptor. Nociceptors are found in all tissues except the central nervous system. The pain is clinically proportional to the degree of activation of afferent pain fiber and can be acute and chronic. It's caused by nerve injuries or disease, as well as by involvement of nerves in other disease processes. Neuropathic pain may occur in the periphery or in the central nervous system. Nociceptive pain. This is superficial somatic pain from cutaneous nociceptor of the skin or superficial tissues. It's typically located and described as throbbing, aching, or sharp or knotting. Deep somatic pain from somatic nociceptors or ligaments, bones, blood vessels. Visceral pain from visceral nociceptors within body organ. It's generally difficult to localize and is described as cramping, achy, squeezing. Neuropathic pain is pain induced by damage to the nerve themselves and by aberrant somatosensory pathways. Hyperpathic symptoms of burning, tingling, and electrical sensation are classic for neuropathic pain. Unfortunately, neuropathic pain is not traditionally responsive to standard medication plan. Herpes zoster can cause neuropathic pain via growing and inflammation within dermatomal nerve. Pain etiology. You have to remember about sympathetically mediated pain is accompanied by evidence of edema, changes in the skin, blood flow, abnormal pseudomotor activity in the region of pain, allogenia, hyperalgesia, and hyperpathia. The afferentation pain is chronic and results from loss of afferent input to the central nervous system. Neuralgia pain is lancinating and associated with nerve damage or irritation along the distribution of the single nerves or trigeminal nerves. Pain etiology also can be due to radicular pain, is evoked by stimulation of nociceptive afferent fiber and spinal nerve, their roots and ganglia. Central pain arises from a lesion in the central nervous system, usually involving the spinothalamic cortical pathways. The pain is usually constant with a burning electrical quality. It's exacerbated by activity or changes in the weather. hyperesthesia and hyperpathia and/or allodynia are invariably present, and the pain is highly resistant to treatment. Psychogenic pain is inconsistent with the likely anatomic disturbance and presumed generator, or it exists with no apparent organic pathology despite excessive evaluation. Referred pain often originated from the visceral organ. It may be felt in body region removed from the site of pathology. The mechanism may be the spinal convergence of visceral and somatic afferent fiber on spinothalamic neuron. Sensitization is an adaptive process in which innocuous stimuli produce an excessive response. Repeated intense stimuli to damaged tissue lower the activation threshold and increase the frequency of firing of afferent nociceptors. Local inflammatory mediators contribute by recruiting additional nociceptors, which normally remain silent to routine stimuli. Central sensitization may also be partly responsible to the pathophysiology of chronic pain syndrome. For example, patients with sunburns often experience intensive pain and discomfort with even very light touch because of sensitization of the pain fiber. Pain modulation can both enhance and dampen pain signals. Pain assessment should be ongoing, individualized, and documented. Patients should be asked to describe their pain in terms of the following characteristics: location, radiation, mode of onset, character of temporal pattern, exacerbating and relieving factor, and intensity. It has been studied the ideal plan measure should be sensitive, accurate, reliable, valid, and useful for both clinical and experimental conditions, and able to separate the sensory aspect of pain from the emotional aspect. Pain must be assessed using the multidimensional approach with determination of the following: chronicity, severity, quality, contributing associated factors, location distribution, etiology of pain, if identifiable, mechanism of injury if applicable, barriers to pain assessment. Pain assessment. Initial assessment of pain should always include the onset of pain and progression in time. Most clinicians and researchers use duration of either 3 months. Recognizing the inception of pain may be crucial in determining treatment. Pain is said to be acute when presenting within the first 3 months from the onset time. It typically has an abrupt start with identifiable associated event, although this may be also always true. Chronic pain does not resolve within 3 months, and its initiation and progresses beyond 6 months of duration. Patients may also be described as constant, irritating, and intermittent. Symptoms may be more severe in the morning upon waking up, later in the day, during the night, depending on the etiology of pain. It's important to document whether patient complains of disturbance in sleep secondary to pain is subjective expression. Objective qualification of pain has been one of the greatest challenges physicians have faced in modern medicine. There is obviously the great variability in the severity of pain among similar cohort groups. Several methods have been devised to measure pain. The quality of pain is described by the patient in the purely subjective manner. Pain that is stimulated by nociceptive ending is usually characterized as thermal, mechanical, chemical. Another common quality of pain is attributed by its neuropathic origin. This pain is often described as burning, tingling, electrical. Nociceptive symptoms often can be amplified by certain body position and/or activity. Frequently, patients complain of pain-inducing positioning and activity that reduce quality of life and in clinical setting. Psychogenic pain is inconsistent with the likely anatomic distribution in the presumed generator, or it exists with no apparent organic pathology despite extensive. It's possible to describe different types of pain, and they tend to present differently. The history and physical examination help to identify these differences because different types of pain tend to respond to different treatments. Referred pain often originated from a visceral organ. It may be felt in body region remote from the site of pathology. If applicable, the mechanism of injury can be directed the clinician to correct path of diagnosis if there is trauma involved, especially if the symptoms are acute. Often, however, the mechanism of injury is due to repeated microtrauma over a long period of time. Barriers to pain assessment occur because of the assessment's heavy reliance on subjective complaints. Pain assessment becomes even more complicated and difficult in patients who are nonverbal or have communication difficulty. Pain threshold is also an issue. There are two thresholds in terms of pain, the perception and the tolerance threshold. The pain perception threshold is the point at which the stimulus begins to hurt, and the pain tolerance threshold is reached when the subject acts to stop the pain. One of the most difficult challenges in chronic pain management is recognizing patients who exaggerate their symptoms for secondary gains, including patients who abuse prescription opioids. Determining the best treatment course for pain management begins with identification and intensity and duration of the pain. Pain assessment relies largely upon the use of patient self-report. Pain management falls into two categories, single-dimensional and multidimensional scales. Single-dimensional scales assess a single dimension of pain, and though patient self-reporting measure only pain intensity. These scales are useful in acute pain. This is numeric rating scale, all phases pain rating scale. Multidimensional scale, McGill pain questionnaire, brief pain inventory, measure the pain intensity, the nature and location of the pain, and in some cases the impact of the pain is having on an activity mood. Although laboratory tests, imaging study, and nerve or muscle conduction study do not show pain in and of itself, their diagnostic modality may help clinicians to identify the root cause of a patient's pain, as well as provide important information to therapeutic planning. Medical management of pain proceeds in the stepwise fashion. First step, mild pain, non-opioid plus adjuvant therapy. Second step, pain persistent or increasing, mild opioid, non-opioid, adjuvant therapy. Step 3, pain persistent or increasing, strong opioid, non-opioid, plus therapy. Acute pain is typically treated with short course of pharmacotherapy, where the chronic pain may require long-acting medication and other interventional modalities. The mild to moderate pain, non-narcotic analgesic are used. Moderate to severe pain, narcotic regimen are used. Analgesics are commonly used for many pain syndromes. Pain control is essential to quality patient care. Analgesics ensure patient comfort, promote pulmonary toilet, and have sedative properties such are beneficial for patients who are having sustained traumatic injury. They are oxycodone, fentanyl, acetaminophen. Non-steroidal anti-inflammatory drugs have analgesics, anti-inflammatory, and antipyretic activity. Their mechanism of action is not known, but they may inhibit cyclooxygenase activity and prostaglandin synthesis. This is ibuprofen, naproxen sodium, diclofenac, and bemetazine, ketorolac. Anticonvulsants, certain antiepileptic drugs, have proven helpful in some cases of neuropathic pain. They are gabapentin. Muscle spasmolytics are traditionally used to treat painful musculoskeletal disorder. As a class, they have demonstrated more central nervous system side effects than a placebo, share and sedation and dizziness as common side effects. This is benzodiazepine, like clonazepam, non-benzodiazepine, carizaperidone, metaxalone, tizanidine. Antidepressant, tricyclic antidepressant, are commonly used in chronic pain treatment to alleviate insomnia, enhance antigenous pain suppression, reduce painful dysesthesia, and eliminate other painful disorders such as headache. Little evidence supports the use of selective serotonin reuptake inhibitors to attenuate pain intensity, and studies have suggested that these agents are constantly effective for neuropathic pain. Many non-narcotic analgesics inhibit cyclooxygenase, the enzyme that is responsible for the formation of prostaglandin, prostacyclin, and thromboxane. Opiate medication mimic endogenous opioid peptide. Pain-controlled analgesia allows patients to self-titrate their intravenous pain medication. This method of pain control also allows more consistent administration of analgesia and shorten the interval between when the patient feels pain and when the analgesia is administered. Transdermal patches provide controlled drug delivery from a lower potential for abuse that is present with oral analgesics, a lower risk of adverse effect, and the reduction in the frequency of dose. Regional anesthesia with therapeutic injections can provide excellent relief for patients with localized pain and inflammation. A transcutaneous electrical nerve stimulation unit is an adjuvant pain control device that provides pulsative low-voltage electrical impulses. Chronic refractory pain is best managed with a multidisciplinary team approach that includes psychology, occupational therapy, physical therapy, osteopathic manipulative treatment, vocational rehabilitation, and relaxation training. Patients with chronic pain frequently seek complementary and alternative medicine treatment options as well, including acupuncture, dietary supplement, and hypnosis. Thank you for your attention.